Joining me in this Tell Me More About session is Nicole Winitsky from Sweden. Nicole, welcome.
Thank you so much for having me.
Yes, glad to have you here. You're an expert in prosthodontics and you're also the co-host of the brand new EAO podcast, Clinical Matters.
Yes.
But right now we're here to talk more about placing implants in young patients, a session that you are talking about here in this Monaco Congress. Let's start with the basics. What is actually the definition of a young patient?
That is such a good question. I have worked on this topic for the last 10 years and doing scientific work on it and also treating patients. And a young patient can be defined in different ways, but what we defined in our research was that we defined this patient group as young adults. Mm-hmm. And young adults is in the period between like 18 and 25 years old.
Yeah.
And we know that within this period of not only a patient's life, but a human's life, a lot of development is still occurring within the face. So that's why this period, called the young adult period, is an important period to look at.
Exactly. And you say I do a lot of work in science about that. I define it as between 18 and 25. Is that an implicit mark that this is maybe not standardized across research in the world?
Yes, we were actually, I was working a lot on that because we were discussing a lot if we were going to call this group of patients young adults, or were we supposed to call them adolescents, or were we supposed to call them only adults? Because if you're over 18, at least in Sweden, you're considered to be an adult.
Yeah.
But we came to the conclusion that it was important to define this period of life as the young adult period.
And you say there's still a lot of development going on. What are some of the key characteristics that implant dentists need to be aware of?
So what's happening is that if you look into orthodontics, they know so much about the growth of the face and the jaws, what's happening all throughout childhood and up until we get adults, but also what happens all throughout life. Mm-hmm. Because our face is actually changing, and we don't really call it growth. We want to call it the continued development of the face. And it actually works different in different patients. So it depends on the characteristics of your face. So you can divide the face into 4 different shapes, you can say, and categorize the patient into 3 different groups, where you have the long face patient mm-hmm. with the oval and quite slim face. They usually have a growth pattern where they grow downwards in a vertical direction. And then you have the like neutral facial type that have a little bit in between. And then you have the squarish facial type with a patient that I would say maybe you are a little bit on the urge to that, with the quite sharp angle of your jaws. Yeah. And the growth in these patients are more horizontal with time.
Exactly. And I guess for the implant dentist, the most important thing I've always learned, the implant doesn't move. So if the face changes, you need to anticipate, I assume.
Exactly. But so what the difference is when you have a patient growing a lot downwards, you also have the mandible is growing or developing and the maxilla is following, and also the teeth are erupting a little bit out of the alveolus.
Yeah.
So we have the movement of the adjacent teeth going inferior and posterior, making the implant end up in a position a bit shorter and with a buccal tilting.
Exactly. And the theme of this Monaco Congress is all about timing. When you describe this movement, are we talking a window of 5 years, 10 years, 20 years, lifetime? I mean, how much speed is involved?
Yeah. What we found in the research that I did, we did a 17-year follow-up of this group of young adults. And we found a movement of the adjacent teeth of 0.05 millimeter per year.
Per year?
Per year.
Okay.
So that's like the rate of movement, 0.05.
In a few years, that's not a lot yet, but over 10 or 15 years, it becomes significant.
Exactly. And also what we were not able to measure, which would have been really interesting, is to maybe first look at the first 7 years and then look at the next coming 10 years, because probably most part of the changes would occur early.
Exactly.
Which is something that we really don't know a lot about. But I am also involved in another research project that is not published yet, where we started now to look from baseline, and we're going to follow them for 1 year, 3 year, 5 year, and 10 years to find out if there are different periods of time where the growth is more advanced or the development is more advanced.
And if you think about it, that makes sense.
Yes.
But obviously, if you're all about science, you want to measure and prove,
Exactly.
right?
Exactly.
Is there anything in general to say about the prevalence of this group of younger patients in an average implant dentistry practice? Like, how many of these patients do we encounter?
No, I don't actually dare to say anything about that. But what I can say is when you look into single anterior implants, which is also my topic, usually there are quite a few young patients that are being treated with these kind of treatments, because these are the patients that either have the aplasias and they're missing 1 or 2 teeth in the upper jaw that they want to have replaced when they're quite young, like around 19, 20, or the patients that had a trauma and they're missing 1 or 2 anterior centrals.
Yeah, it's typical for that age group.
Yeah.
Do you feel it's actually is or should be a specialization? Is it the patient group that you should specialize in, or is it just being aware of some of these insights you bring and then everybody could do it?
That's also a really interesting question. I come from the Eastman Dental Institute in Stockholm. And when the Eastman Dental Institute was built, it was a house built only for children and young adults. So in that building, there was one department called the Department for Juvenile Prosthodontics. So all the young people in need of prosthodontics in the greater Stockholm area were centralized into that department, which of course gave these people working there a greater knowledge about how to treat these patients when they are still growing, when things are still changing.
Yeah.
Because when you treat a 60-year-old, it is actually something else.
Yeah.
Both physically but also mentally.
For sure.
So so you can say that it's a little bit of a mix between being a prosthodontist and a pedodontist.
Exactly. So, and I also get a hint that you would say, well, at least I'm glad in an institute where we are specialized specifically for this patient group.
Yeah, exactly. Now, this department doesn't exist anymore.
Okay.
Now the department merged.
Yeah.
So now we're doing all things. But I think it's really important. We have 1 or 2 dentists, or I'm not working there anymore. But when I was, there is always someone with a special focus towards the younger group.
Exactly.
Because there are things that you need to know.
Let's see if we can take it one step more practical. So we've learned, okay, dentists, be aware, you need to anticipate at, the word is not growth, but development. So what does that look like in practice? So can you take us in, what are some of the precautions or steps you take in a protocol to anticipate this?
I want to go back in time a little bit, because in the early days when we started to treat these patients with single anterior implants, the young patients, you took some kind of measurements to see if the patient's somatic growth had ended or not. So you can do that by taking an X-ray of the hand. We didn't do that so much. We ask the patient, how much did they grow the last year?
Oh yeah.
Did you grow out
kind
of your pants?
Kind of a proxy, like, is this done? Yeah.
But we should be aware of that this development is continuing all throughout life.
Yeah, that's the new insight maybe, for the recent years.
And that is, so many people see, we all see it. You can treat a 50-year-old with a single implant, and he or she comes back 5 years later and it's not in the same position, and you have interproximal contacts that have opened up. So there are so many things that are occurring.
Yeah.
So I would say that I wouldn't. Of course, you want the patient not to be too young. Like, I would never treat a patient with a single implant before 19, 20. But then it all comes up to the patient's need for an implant. I mean, there are other kind of treatments that we can do. We can do the resin-bonded bridges. They come out beautifully today. So I would say that try to postpone the implant treatment for as long as possible for all our patients, all our young patients.
As a general concept of treatment?
Yes. So if you have a 19-year-old and you can actually treat this patient with a resin-bonded bridge, and he or she can have that for 10 years, then we have helped this patient to get a shorter span of the time with implant, because that's also something tough. When we treat a 19-year-old, there are so many years that these implants are supposed to be in use. And we don't even have that kind of follow-up time.
Exactly. I spoke to
they say-
someone earlier who received an implant actually as a youngster at his 17. He said they told me the implant was for life, and now they discover, this was about 20, 30 years ago,
exactly.
it's only perhaps for 20 years. So it's relatively new field of study, right?
What I say to my patients is that we expect your implant to stay in your mouth and to be healthy for hopefully the rest of your life.
Yeah.
But you have to be prepared that the crown on top of the implant will need to be probably exchanged, repaired, maybe exchanged at least once or maybe a few times during this long lifetime.
Exactly. And as long as you manage that expectation up front, and I guess that's part of a normal treatment approach.
Yes.
I am a bit fascinated by your general comment, let's see if we can postpone the implant as long as possible, because that brings me to a point. Okay, you identified young patients as between 18 and 25. So when I come in as a 26-year-old, is that still your attitude, or like where's that?
Yes,
where does that
still
gray
my
area?
attitude.
Where
No,
does that
still-
gray area end? Yeah.
No, I still think a 26-year-old would be better off having their implant at 36.
Okay.
We can do something else for 10 years. But something else that is really important is the smile line of the patient.
Of course.
So if the patient have a high smile line and you get an infra position after 5 or 10 years, it turns out really, really unaesthetically.
Yeah.
And the patient will not be pleased, and he or she is showing everything.
Yeah.
So I'm even more cautious with the patients with a high smile line. Because the low smile lines, we can make them a longer crown, we can do some adjustments, and it will look really nice anyway.
Yeah.
But the high smile line patient, and usually they are also the same patient that has the long facial type.
That is the typical type of patient that run into that.
It usually comes together.
Yeah.
Long facial type usually also have a high smile line. So that makes that patient category a little bit more of a high risk. Even though we didn't show that actually in our research, we weren't able to show that was the risk patient.
This is partly clinical experience that you share here.
Yes.
Exactly.
Because we're looking at implant and patient characteristics, because we wanted to find out if we could find some some characteristics that could help us to predict the future risk for infraposition.
Exactly.
So the dream would be to have a patient coming in and that I could say to you, okay, I can see because you have these and these features that you have quite a great risk of receiving a greater infraposition over time.
Yeah. And then just to be super clear, would you then already anticipate that in the initial implant or implant placement, like perhaps making a little bit longer, or would you go what you just said, say, so be aware, dear patient, I want to see you back in 10 years or something for a new crown. What is your...
I would not make the implant crown longer because no patient will be pleased with going out of the clinic having a non...
It doesn't feel nice, but in 10 years it will be fine.
Exactly.
Yeah.
But what we're talking a lot about today is maybe to place the implant a bit more palatally. Because it's also a problem when the implant ends up in two buccal position within the bone and the soft tissue can become very thin.
Yeah.
So I think that's something that we should look into to doing.
Exactly. Well, that's very practical advice. Final question. If people walk out of your session here at Congress today, what do you hope? What is one thing they really take away back into either their clinical practice or perhaps if they're researchers, into future research?
There are a lot of things, but if you say future research, I would really like to ask all the researchers out there that are working with implant infraposition to add the parameter, the measurement of the lower anterior facial height. And that is the measurement from underneath the nose to underneath the chin. Because that was the parameter that we found that if you have a lower anterior facial height of less than 70 millimeters, then you have a less risk of severe infraposition.
Exactly.
But today, we are the only study who have been putting that parameter in. So it's only one study that has been showing this. But if some other Researchers
I'm now
replace
super
it.
practical, but is this a measurement that I could go back and take out of photographs, or is it something that really needs to be measured in situ?
No, we actually did. You can do both.
Okay, so in potential, there's a lot of data of all those
Yes.
patient
Yes.
photographs
Yes.
out there.
Yes.
That's an interesting
Could be.
study.
Now, when we have measured this for research, we have done very specific pictures with specific angles and
course.
the cameras in the right positions so that we should get the right measurements. But yeah, I think that could be done.
Cool. So that's an advice or an ask to all the researchers watching. Any key message for the clinicians?
Yes.
What should they do tomorrow?
I think that we should always inform our single implant patient that receives anterior implants of this risk of infraposition so that they are aware of it. I think that we should always postpone the treatment on this younger group of patients for as long as possible. I think that we should always screw retain our crowns to as large extent as possible so that we
Allow
can
more
easily,
flexibility.
so that we can more easily exchange them when it's needed, because it will be needed in this group of patients. And I think that's about it.
super clear, yeah, and that sums it up perfectly. Well, thank you, Nicole, for taking time out of your busy schedule to be here with us and tell us more about placing implants in young patients. And thank you for watching this episode of Tell Me More About. Go out onto the Monaco online platform and discover all the other scientific content available to you.